Good afternoon, everyone. Welcome to this afternoon's deep dive session presented by University of the Free State. I'll be chairing the session. I just want to make sure that I'm loud and clear. Everybody can see me and my slides are showing.
Looks great, Shak.
Okay. All right. So our topic today is going to be mastocytosis, and I'm going to before we go into that, I'm just going to do some housekeeping. So the recordings can be found on at bloodsa.org.za and under resources deep dive. Please feel free to ask any questions or comments in the chat box, and I'll get to them. If you are not on the mailing list, please email Melanie Davids at uct.ac.za. And the CPD points will be automatically submitted. If there's any questions, you can also email Melanie. 1 hour attendance is needed for the CPD points. And please do complete the survey at the end. We do value your feedback and comments. Just a reminder of some upcoming conferences. There's the 14th International Donor Registry Conference, WMDA meetings in Cape Town from the 25th to the 29th of June. And there's discounted rates for members of Satiba, Sashas, and Blood SA. And yeah, so please, for more info, go to the link at bloodsa.org.za for info on the upcoming events. There's also the 16th Annual Hematology Oncology Symposium on the 13th to the 15th of September at Century City. That one's going to be very exciting, so please register for that. We just want to thank our deep dive management team, Prof. Berg for leadership, Khadin as coordinator, Melanie Davids, a CPD administrator, and Bridget McMillan also coordinating these sessions. My colleague, Dr. Anneke van Marle, will start. I will first start with a bit of a case, and then Dr. van Marle will take over and talk on the diagnosis and classification. And then I will speak on the treatment of mastocytosis, specifically systemic mastocytosis. Just a note, unfortunately, next week's deep dive has been cancelled, so nothing next week. For those of you who don't know Dr. van Marle, she's a colleague of mine here in the lab, and she's a valuable member of our laboratory team. Very interested in. She's the go-to person for flow cytometry, any questions on flow cytometry, and she's a wonderful colleague. Then myself, I'm not going to say much more about myself. So without further ado, let me just quickly go to my first slides to start with the case. All right, so our topic is systemic mastocytosis. Can I just confirm? Oh, wait, I've not shared it yet. Just give me a second. Okay, hopefully it shows now. Just let me know if it's not showing. So I'm running a little bit of an experiment. There's 2 question slides that will come at the end of Dr. van Marle's presentation, as well as after mine. These are going to be interactive, word cloud based. Hopefully we'll get the results live. So you could maybe point one of the tabs in your browser to menti.com and enter the code there. The code will also be shown on the question slides, and there'll also be a QR code, and then you can answer the questions there. Hopefully it works. I've not done this before, so we'll see how it goes. All right. So in terms of, I thought it's important. It may be useful to start this discussion with a case. I don't think any of us see mastocytosis very frequently, and it's always yeah, I think every time I see a mastocytosis, I just need to reset my mind and go and look up the the workup and so forth, because we don't see it every day. So the case I'm presenting is a Mrs. CJ. She's currently a 45-year-old Caucasian female. She was diagnosed at the age of 20, so 25 years ago, with adult onset urticaria pigmentosa or cutaneous mastocytosis. Although these aren't her photos, lesions look exactly like this, the typical brown, fleshy macules that you'll see. And she reports that over the past 8 to 10 years, these lesions have gradually increased in number. And this photo panel taken from up to date shows this not infrequent finding of adult onset mastocytosis of gradually increasing lesions. Often they start on the thigh and then spread from there. Mrs. CJ's lesions is currently sort of to the extent of panel E. She does not have confluent lesions like in panel F. And it currently involves more than 80% of her skin. Before she consulted me for the first time, she presented in 2016 with 2 episodes of anaphylaxis. The history of what were the triggers is uncertain, and she's not had any anaphylactic episodes since then. She first consulted me in 2019, and her main concern was she was extremely worried about progression to systemic and advanced mastocytosis. She was especially worried about developing, she's obviously read up on this condition, and she was very concerned about the development of mast cell leukemia. And this was a main concern and main complaint, essentially. However, she was actually very symptomatic. With significant symptoms of chronic pruritus, generalized arthralgias, chronic diarrhea and abdominal cramps. And these symptoms over the past 10 years or 6 years, 6 to 10 years have gradually worsened and actually have significant impact on her quality of life, although she's learned to live with it. These symptoms are improved, but still significant despite chronic use of cimetidine, H2 antihistamine, levetiracetam and H1 antihistamine, montelukast, mast cell stabilizer, as well as esomeprazole. But apart from abnormal skin examination, as mentioned, the rest of her clinical exam was completely normal, and she had no organomegaly or lymphadenopathy or any other abnormalities on clinical examination. So she was sent for some special investigations. Her full blood count was completely normal. There were no abnormal cells. There was definitely no mast cell circulating. Biochemistry, renal function, liver functions, calcium, magnesium, phosphate, they were all completely normal. She did not have an hyperalbuminemia. Her bone marrow, however, showed on the aspirate about 1% mast cells. And of note, on the one bone marrow section, and this was actually shown on she's had 2 bone marrows since, but there was on the one bone marrow, or the one that I'm showing here, there was a focal paratrabecular infiltration of mast cells, which was demonstrated by CD117 and Giemsa staining, and these consist of about 20 mast cells with highly abnormal morphology. They were spindle-shaped and they had enlarged nuclei. And this focal infiltrate was surrounded by an interstitial presence of morphologically abnormal mast cells. The serum tryptase has been persistently elevated. At this investigation in 2019, it was 35.7 with a reference range of 0 to 13.5. And this is generally where her tryptase is on multiple repeats. KIT mutational analysis was negative on the bone marrow sample. Gastric, duodenal, ileal, colon, and rectal biopsies were all negative for mast cell infiltration, completely normal tissue. She had no whole body low dose CT scan was normal with no lytic lesions, and her bone density was normal. So with that, I'm going to hand over to Anneke to take it from here, and after her presentation, we'll go ahead with the rest of my talk. I'm just going to stop my share. Anneke, you can you can start your share.
Thank you, Jock. Oh, can I just confirm, can everybody see my screen?
Yes, we can.
Okay, thank you. So good afternoon, everyone, and thank you for the opportunity to present. So I always like to start my talk with a theme, and sometimes my theme fits perfectly with my topic, and sometimes you may need to use some imagination to appreciate the analogy. But nonetheless, the title for the talk today is When the Elephants Are in Must. And I thought to start off the talk, I'll show you a video just to illustrate the importance of the elephants in this talk and what they represent, which is essentially the guardians of the forest. Oh, sorry, I don't know why it's not advancing. Oh. Oh.
Created this job. They made funnels with their tusks, the rivers ran. They blew their trunks, the leaves fell. They made all that belongs.
Okay, so what does it mean if an elephant is in must? So I thought let's just go back to the origin of the word must as we know it today. So it was actually originally spelled as must, like we spell must cells today. And it means intoxicated, but over use of time, the spelling has changed to the M-U-S-T-H spelling as we know it today. And it actually means a condition of heightened aggression and unpredictable behavior that occurs annually in certain male animals, especially in elephants.
I chose not to hoot or anything like this for fear of actually aggravating the elephant because it was a fully grown male. And also he looked a little bit agitated. They were getting too close. The elephant turned in front of them and then kind of very shortly after that, they didn't move and the elephant turned their car over and pushed them off the road for about 20 meters into the bush.
Brooks was gored in her upper thigh and was hospitalized. She's since been discharged. De Klerk suffered only minor injuries. Park authorities later put the animal down. They said it was in must and had shown aggressive behavior before.
So on that note, let's start with some history. So Paul Ehrlich was a Nobel-winning German physician and scientist born in 1854. And as a 24-year-old medical student from Strehlen, he presented his doctoral thesis to the medical faculty of the Leipzig University, and it was entitled Contribution to the Theory and the Practice of Histological Dyes. And during his research, he identified a new type of cell that he coined mast cell, or in German Mastzelle. And this he referred to as a connective tissue cell that was localized around the blood vessels in the connective tissue. But he stated that although these cells were perivascular, they were not part of the perivascular system and could clearly be distinguished from another group of cells that were found perivascularly, and these were called plasmacellen at the time. So he described them as granular cells characterized by the presence of a still undetermined chemical substance, which is bound to the granular storages of the protoplasm and which reacts to aniline dyes, giving it a typical metachromasia. So metachromatic staining means that is when tissue reacts to a dye and then it shows a different color from that of the original dye. So when these cells were stained with cyanine dye, it would change into a red-violet color. For fusion dye, an orange color, and Jensen violet stained red in color. So from a descriptive point of view, he said that these cells should most conveniently be described as granular cells of the connective tissue. But from a physiological standpoint, he said that they are Mastzellen, the word mast coming from the Greek word breast, which denotes nourishing, fattening, or suckling, because Ehrlich believed that these cells had a nutritional function due to their granules. He noted that mast cells were abundant in states of chronic inflammation and in tumors, and he ascribed this to the nutritional requirements of the tissue, and then found that they were diminished during periods of starvation. So the normal mast cell is derived from the CD34, CD117 hemopoietic stem cell, and it goes through different stages of maturation. from an ungranulated tryptase positive blast to a metachromatic blast. Then you get your promastocyte. And then finally, the round mononuclear mature mast cell that we know with the metachromatic granules. And mast cells are distributed throughout the body, typically at these sentinel sites where pathogens may invade the body. So the dermis, the gut mucosa and submucosa, and airways. And it's usually in close proximity to blood vessels, lymphatics, and nerves. And morphologically, these cells are round or ovoid in shape with eosinophilic granular cytoplasm, as you can see here on an H&E stain. And they've got small, round, hyperchromatic nuclei without nucleoli. But of course, on Romanowsky staining, you see this metachromatic properties where they stain this intense purple on a May-Grunwald Gimsa. Apologies, and here in the toluidine blue, again, also quite an intense purple, but with a chloroacetate esterase stain, you get this red-orange color. So the normal mast cell participates in the innate defenses against certain viral and bacterial infections, but also parasitic infections. And it is activated when the Fc epsilon receptors are cross-linked. So they can be cross-linked by multivalent antigens or by lectins. There's chemical cross-linking, even anti-IgE antibodies can cross-link these receptors. Upon cross-linking, you then get activation of the mast cell with release of mediators. So they are the preformed mediators, and these are released within seconds to minutes of activation and include your histamine, your neutral proteases, the heparin proteoglycans, which are actually responsible for these metachromatic staining properties of the mast cells, and then some cytokines like tumor necrosis factor alpha and interleukin 8. And these are mainly responsible for the acute symptoms and signs that we see with allergic reactions, such as edema, bronchoconstriction, increased vascular permeability, and increased mucus and gastric acid secretion. Then you get mediators that are released or formed actually upon activation. So it usually only appears about 15 minutes to even several hours after activation. These lipid mediators are formed de novo from the membrane phospholipids, and this includes your echinosoids, so the prostaglandins, leukotrienes, and platelet activating factor. They are important for cell recruitment and antigen presentation, and the leukotrienes are actually also referred to as your slow-release substances of anaphylaxis, and they contribute to some of the symptoms and signs like airway obstruction and prolonged smooth muscle constriction. And then you also get release of cytokines and chemokines, mainly your Th2 cytokines, so interleukins 4 and 5, and again would play a role in recruiting and activating other cells of the immune system. So in a controlled environment, these vasoactive mediators would usually function to protect the body from microbial invaders and result by just causing by creating a very localized or controlled inflammatory reaction. But the symptoms and signs that we see with the sudden, extensive, and uncontrolled mast cell mediator release are those that you would see with anaphylaxis. Now, apart from the role of in the immune system, mast cells do play a role in the connective tissue homeostasis, remodeling, repair, and angiogenesis. So although not strictly speaking involved in nutrition as Ehrlich initially thought, mast cells do exert some trophic effects. Now, CD117 or KIT is a very important receptor found on the surfaces of mast cells. It is a type 3 receptor tyrosine kinase, and its ligand is the stem cell factor. Apart from mast cells, CD117 is also expressed on hemopoietic progenitors, germ cells, melanocytes, and also the interstitial cells of Kujal and the GIT. But KIT expression is generally then downregulated as hemopoietic cells undergo differentiation and maturation, but not on mast cells. Mast cells retain high levels of CD11 expression throughout their lifespan. And as soon as the ligand stem cell factor binds to the receptor, you get dimerization of the cytoplasmic domains of this receptor, and this results in activation of several downstream signaling pathways, including your JAK-STAT pathway, the phosphatidylinositol trikinase pathway, as well as the RAS-MAP kinase pathway. And these pathways all promote the proliferation, the growth, and the survival of mast cells. So now getting to my analogy, some of you may be familiar with this book. I consider this one of the treasures in Afrikaans literature. And this was the inspiration for my analogy. So I would like you to imagine that the forest is like the body, and elephants, in particular the old bull oakwood from this book, would be like mast cells, the guardians of the forest. And when these elephants are in mast, obviously chaos would follow. And likewise, I would want to say that if mast cells are in mast, then mastocytosis will follow.
Get out, get out, get out.
So mastocytosis is actually a rare disease. It's got a prevalence of about 1 in 10,000 individuals that are affected. Both sexes are affected, but there's a slight male predominance in children and a slight female predominance in adults. And it's got quite a varied presentation, from skin-limited only disease to aggressive systemic disease with multi-organ failure. And it is characterized by this pathological accumulation of abnormal mast cells in various tissues and organs. And in 95% of cases, it's driven by this gain-of-function mutation in KIT, resulting in a constitutively active KIT receptor tyrosine kinase, which then constantly triggers these signaling pathways, as I've mentioned previously, and it induces abnormal and uncontrolled proliferation and survival of these mast cells. So in 2022, there were 2 independent updates from the previous 2016 WHO classification for mastocytosis, or disorders of mast cells. They are very much the same even today. Both classifications have the 3 major categories. You've got your cutaneous forms, your systemic forms, and your localized mast cell tumors. I'm just going to highlight the big differences. So under systemic mastocytosis, in the WHO, bone marrow mastocytosis is an entity on its own, whereas in the ICC, it falls as a subclassification under indolent systemic mastocytosis. And then in the WHO, they still refer to systemic mastocytosis with an associated hematologic neoplasm, whereas in the ICC, they now refer to it as an associated myeloid neoplasm, because they said that in more than 90% of cases, these malignancies will be myeloid and also share the same somatic molecular mutations as most common myeloid malignancies. Then just a word on childhood versus adult onset mastocytosis. So childhood onset mastocytosis is usually limited to the skin and often undergoes spontaneous regression with age, usually by the time the children reach puberty. Whereas adult onset mastocytosis tends to be persistent, have multi-organ involvement, and usually is associated with a concurrent non-mast cell hematological neoplasm. But it's very important to know that childhood versus adult mastocytosis does not equal cutaneous versus systemic mastocytosis, because although by far the majority of kids will have cutaneous mastocytosis, children can have true systemic mastocytosis and even advanced forms of the disease. And likewise, although more than 90% of adult mastocytosis will be the systemic forms, adults can also have new onset cutaneous only mastocytosis. In both cases, they are also associated with activating KIT mutations, but the specific mutation may differ. In more than 90% of adults, it will be the specific mutation, the D816V mutation, coded for on exon 17 of the gene, and it codes for this tyrosine kinase domain of the receptor. It is a single base substitution where an adenine is replaced by a thymine, resulting in a single amino acid change, an aspartic acid for changes to a valine. But this is regardless of whether it is cutaneous or systemic. In more than 90% of adults, that would be the mutation. In children, however, this specific mutation, D816V, only accounts for about 35 to 40% of all the KIT mutations in mastocytosis, again, irrespective of whether it's cutaneous or systemic. In about 40% of childhood mastocytosis, they get mutations in exons 8 to 11, which code for the transmembrane domain, and up to 20% of childhood mastocytosis have wild-type KIT without any demonstrable KIT mutation. So cutaneous mastocytosis, as the name implies, is confined to the skin. So you require histological proof of abnormal mast cell infiltration in the dermis, with no evidence of systemic or bone marrow involvement. They may have one or more of or two of these minor criteria, but not sufficient to fulfill the criteria for a systemic mastocytosis. It is considered rare and can occur at any age, but most commonly will affect children and may even be present at birth. And about 50% of children that will be affected will have shown skin lesions by the time they reach 6 months of age. And as mentioned previously, slight male predominance in children, and often you get spontaneous regression of these skin lesions by the time they reach puberty. There are the three main forms, your maculopapular cutaneous mastocytosis, of which you get the two variants, monomorphic and polymorphic, diffuse cutaneous mastocytosis, and mastocytomas. As mentioned again, it is often and strongly associated with activating KIT mutations, and that depending on whether it's children or adults, various percentage that would specifically be associated with the D816V mutation. These patients may present with swelling, erythema, pruritus, blistering, and also the classic Darier's sign, which is a urticarial reaction that follows when these lesions are stroked. It can also be elicited by heat, cold, alcohol abuse or use, and stress. Now, these patients, although may have systemic symptoms, but this is not due to systemic mast cell infiltration, it's due to mast cell mediator release. So they may have flushing, headaches, diarrhea, even full-blown anaphylaxis. The monomorphic form of the cutaneous mastocytosis is the most common form, also the most common form in adults. And this is the classic form that is referred to as your urticaria pigmentosa. And it is characterized by these small yellow, tan, sort of to brown, red macules and slightly raised papules, often on the trunk and extremities. The polymorphic variant of the polymorphic cutaneous mastocytosis, consists of larger lesions, often confluent, and they tend to be of variable sizes. And then your diffuse cutaneous mastocytosis is almost exclusively seen in children, often in infants, and they tend to have the thickened skin, this leather or orange peel skin, and may have blistering. So this is just a slide of showing various presentation of specifically diffuse cutaneous mastocytosis, varying from the thickened skin to these fine papules and skin folds, this exaggerated or pronounced dermatographism that they may see, and then variable degrees of blistering for specifically diffuse cutaneous mastocytosis. Now, systemic mastocytosis is defined as clonal neoplastic proliferation of both morphologically and immunophenotypically abnormal mast cells, which would accumulate in one or more organ system with or without skin involvement. It is strongly associated with this gain-of-function mutation in KIT, again, most commonly the D816V mutation, and again, this would have a heterogeneous disease with variable clinical course. Of the systemic mastocytosis, which is the biggest category of mastocytosis, by far the majority, about 70% and more, will be the indolent systemic mastocytosis group. This needs to be differentiated from your idiopathic mast cell activation syndrome, which you would find that these patients have the symptoms and signs associated with mast cell activation, but they do not have morphologically or molecular abnormal mast cells. Monoclonal mast cell activation syndrome, in this case, you have proof that these mast cells are abnormal, either because of the presence of a KIT mutation or aberrant immunophenotype or both, but again would not fulfill the criteria for systemic mastocytosis. So if you look at the abnormal morphology, these would include multifocal clusters of mast cells, and this is actually the major criteria when you want to diagnose systemic mastocytosis, usually saying clusters of 15 or more mast cells present. But remember that up to 25% of cases of systemic mastocytosis may lack any form of clustering. Then they can also have these spindle-shaped, often also referred to as kite-shaped or triangular-shaped or fusiform shaped mast cells. This is a nice example with the long polar cytoplasmic processes. They can have hypogranularity or uneven distribution of fine granules, atypical ovoid nuclei, and may even have monocytoid appearance. Two things to note for hematopathologist is that you cannot use this abnormal spindle shape as a criterion if these mast cells line fat cells or vascular endothelium on your trephine. And you also cannot use this atypical morphology as a criteria if this is found immediately adjacent to a particle on a bone marrow aspirate smear. So this is a slide that I actually borrowed from Prof. Karl Sattler from Salzburg in Austria. He presented a talk on mastocytosis at the EHA in 2022. And I thought this is just a beautiful illustration of the different types of mast cells we see. So the normal mast cell is round with lots of granulation obscuring the nucleus. Your type 1, atypical type 1 mast cell is the classic spindle-shaped mast cell with the ovoid nucleus and uneven granularity. Type 2 mast cells would often have multi or binucleated forms and again uneven distributed granules. And your type 3 or metachromatic blast shows increased nuclear cytoplasmic ratios with also sparse granulation, and it may even be indistinguishable from a basophil precursor. So when we think of abnormal immunophenotype, what does that refer to? So normal mast cells will express CD117 and tryptase. That is just to identify mast cells or these clusters of mast cells. But they should usually express aberrantly CD25. This is the most sensitive marker, usually around 100% sensitivity in abnormal mast cells. Or CD2 expression. This is more variable, and it's also very much dependent on the fluorophore conjugate that you use on flow cytometry. So if you use the CD2 PE conjugate, you've got about an 83% sensitivity of picking up this abnormal phenotype. But if you're going to use the FITC conjugate, it's only about 67% sensitivity. And then CD30 was also later added. You may see CD30 expression in a subset of these abnormal mast cells. And it was previously thought to have a prognostic implication and to identify those cases that are more likely to behave aggressively. But subsequent studies have not confirmed this association. So then when you're looking specifically at the criteria to diagnose systemic mastocytosis, again, looking at the two bodies now, WHO versus ICC, it's very much the same. Both have 1 major and 4 minor criteria, and you only require 1 major and 1 minor or 3 minors to make the diagnosis. And it's pretty much the same. You need the multifocal dense infiltrates, more than 15 mast cells in an aggregate for both, but the ICC specifies that these infiltrates need to be tryptase or CD117 positive, just confirming the mast cell origin. And then for minor criteria, again, these atypical cells in 25% or more, that is for both, the activating KIT mutations or another KIT mutation in a critical region, or the 816. You need the abnormal immunophenotype, both of them refer to that. And then you need an increase in your serum base tryptase concentration of more than 20 nanograms per milliliter. Something that the WHO adds is that if you know a patient has hereditary alpha-tryptosemia, you need to use a calculation in which you adjust the level to make sure that it truly meets the minimum criteria. So hereditary alpha-tryptosemia is a common genetic trait. It affects about 6% of the general population. It is inherited in an autosomal dominant fashion, but it's got variable penetrance. And it is basically just associated with increased serum baseline tryptase levels. Patients can be completely asymptomatic, or they may present with recurrent anaphylaxis. This is from up to date, and this is actually still based on the 2016 classification, but the principle or the basic classification remains the same. You really have to differentiate between your non-advanced and your advanced forms. So the non-advanced systemic mastocytosis would include indolent and smoldering. For indolent, you may have 1 B criterion, but no C criteria. For smoldering, you can have 2 or more of your B findings, but no C findings. And then when you look at the advanced forms, it includes aggressive systemic mastocytosis, where your C findings would be present, mast cell leukemia, where you would have 20 or more mast cells in your bone marrow aspirate, and then the systemic mastocytosis with an associated hematologic neoplasm. Now, just a word on this. This would be the most common subtype of your advanced systemic mastocytosis. And very importantly is to note that the AHN, or the associated hematological neoplasm, actually drives the prognosis, because the AHN can be associated with any form of systemic mastocytosis, including your indolent and your smoldering forms. So it's not necessarily the mast cell component that is the aggressive part of it. And when you want to assign these B and C findings, you have to make sure what is actually causing the organ damage. Is it the mast cell infiltration, or is it the associated hematological neoplasm? So there's also been updates on the B and C findings from both the WHO and the ICC, and I'm just again going to highlight the big differences. Just to clarify, the B refers to the disease burden or the mast cell burden, and C findings refers to cytoreduction necessary or required. So when looking at the B findings, it's very much the same. You still need 30% or more mast cell infiltrates in the bone marrow. And again, a raised serum tryptase level of more than 200 milligrams per milliliter. to make it a B finding. But then the WHO has now also added the KIT D816V variant allele frequency of more than 10% in bone marrow or peripheral blood leukocytes, so non-mast cell lineages, hemopoietic cells, and this actually has prognostic implication. Then the second criteria of B finding would be signs of myelodysplasia or myeloproliferation. It remains the same, but they've just added some more detail, specifically mentioning the presence of eosinophilia, which I'll allude on a little bit later. I'll just elaborate on that a bit. And also mentioning that the signs of myelodysplasia may be present, but should be less than 10% for the respective lineages. And then your third B finding would be the involvement of organ without organ dysfunction. So hepatomegaly, splenomegaly, or lymphadenopathy, but without organ impairment. That remains the same. They've just added specific measurements on ultrasound for the lymph nodes. And just to show you that this differs from the ICC, where they use 1%, more than 1 centimeter cutoff. For C findings, you've got now impairment of organ function, so you would have bone marrow involvement with cytopenias, the cutoffs remaining the same, in an enlarged liver with liver impairment, so it remains the same, the portal hypertension ascites, but they've added liver cirrhosis here. For skeletal involvement, again, they've added a measurement to the osteolytic lesions, and then they also refer again to the pathological fractures, and then you would have a palpable spleen with hypersplenism. They've added weight loss and hypoalbuminemia, and same again for malabsorption with weight loss. They've added the hypoalbuminemia. Then there's a new entity, well-differentiated systemic mastocytosis. It is a distinct and a rare variant, which is recognized by both these bodies. It frequently has childhood onset, but will persist into adulthood. It is characterized by round, well-granulated mast cells, with the absence of this aberrant CD25 and 2 expression, but they would usually have aberrant CD30 expression. It is associated with a non-D816V KIT mutation, and that renders it sensitive for imatinib therapy. So when looking at clinical presentation, patients may have constitutional symptoms, the skin manifestations, as I've mentioned previously, mediator release symptoms that can involve any organ systems, from abdominal symptoms, respiratory symptoms, cardiovascular symptoms, full-blown anaphylaxis, and then those symptoms that arise from the non-cutaneous organ infiltration, and that will depend on the organ system that is involved. The symptoms that are associated with the non-muscle hematological neoplasm will also, again, depend on the underlying neoplasm, but often would involve cytopenias. So this is a nice figure from the update, the AJH update on systemic mastocytosis from 2023. And it just shows that this is a spectrum of disease, starting with this sort of pre-malignant systemic mastocytosis, or the monoclonal muscle activation syndrome, through the non-advanced forms all the way through, and then involving finally to the muscle leukemia, which is the most aggressive. And as the disease burden increases and the organ dysfunction worsens, you'll see that the mast cell mediator release symptoms and skin symptoms become less prominent. So although these skin manifestations and mediator release symptoms may be present in all of the different forms, this is by far the greatest morbidity and even mortality in terms of anaphylaxis in your indolent forms are contributed to by the mast cell mediator release symptoms. This is another slide that I borrowed from Professor Andreas Reiter from Germany, again, also presented on mastocytosis at the EHA. And he said this is all you need to your path in the diagnosis and subclassification for systemic mastocytosis. So patients presenting with these symptoms, you should reflex testing for systemic mastocytosis. He said, in fact, any adult with new onset skin lesions or anaphylaxis should always have a serum tryptase level done. And he is of meaning that you can only do a bone marrow, a serum tryptase level, and a KIT D816V mutation with the variant allele frequency would be sufficient to confirm the diagnosis. You would then identify C findings, it's the ones highlighted in red, to help you subclassify your systemic mastocytosis. And your myeloid NGS and cytogenetics would help with further prognostication. So I'm going to just run through this diagnostic algorithm. It's also from the AJH update. And they start with a serum tryptase level, but I would want to go back a bit and say you can start with an FBC. The FPC, the diff and the peripheral smear can already give you some indication. You may either see cytopenias, or you may see different things like eosinophilias and monocytosis that may suggest a different type of MP and MDS overlap, for example, which is a distinct entity which would be treated differently, but may also have increase in mast cells, although not systemic mastocytosis. And then, of course, you may actually see underlying hematological neoplasms that be associated with the systemic mastocytosis. Then when you get to the serum tryptase levels, there are a few pointers that you need to remember. It is elevated in most patients with systemic mastocytosis, but the absolute level does not necessarily predict the category. So although it's much higher generally in your advanced forms, up to 5% of patients, even in advanced forms, may have low serum tryptase levels. And then Prof. Bozay in his recent talk on systemic mastocytosis actually said that neoplastic mast cells are not equal opportunity organ offenders. So you can have a low bone marrow tryptase, mast cell burden with severe liver disease or vice versa. But as a general rule, the serum tryptase level will correspond to the mast cell burden in the bone marrow. Then it's also important to remember those patients that have hereditary alpha-tryptosemia that you need to adjust the levels. Also, an important thing that I didn't mention previously was that if a patient is known to have an associated myeloid neoplasm, you cannot use this serum tryptase level as a criteria to diagnose systemic mastocytosis, because patients with myeloid neoplasms will have elevated serum tryptase levels, and therefore this would not suffice. It's also important then that you require a baseline level. It's no use in taking your serum tryptase level immediately after a mast cell mediator released episode, because this may as well just be elevated due to anaphylaxis and not due to the underlying systemic mastocytosis. And then you can reliably do serum tryptase levels even if a patient is on anti-mediator therapy, unless he's been on long-term corticosteroid therapy. So the next point in this diagnostic algorithm would be to look at the bone marrow. And here you would specifically look therefore for the clusters or the aggregates of mast cells, the abnormal morphology, and then of course the abnormal immunophenotyping, either by immunohistochemistry, as you can see here in these aggregates, or by flow cytometry. So this is actually a case that we had in our laboratory where we did flow on. So to show you, the mast cells have the same complexity as that of eosinophil, so high up in the CD45 side scatter, rightly expresses CD117. And then you can see here that it expresses CD2. We unfortunately use the CD2 FITC, and as I mentioned previously, the sensitivity is slightly lower than the PE, but you can see that if you use your T cells as your internal reference population, it's dimmer than the Ts, but at least brighter than the Bs, which would be the internal negative control, and then of course being positive for CD25 compared to our internal negative controls. The next step would then be to look at your molecular tests. And again, Prof. Andreas Reiter felt very strongly that you can actually subclassify your systemic mastocytosis by just using the combination of a tryptase level and your expressed allele burden of the KIT D816V mutation. He said if both the tryptase level and the burden is low, it's an indolent form. If you've got low tryptase levels with high KIT burden, it is usually a systemic mastocytosis with an associated hematological neoplasm. Whereas if both are high, it's one of the advanced forms of the disease. A very important fact to note is that you need a very sensitive technique to diagnose your KIT mutation. So normal NGS is not sensitive enough to pick up these pathogenic mutations. You either require allele-specific oligonucleotide quantitative real-time PCR or a digital droplet PCR, because they can detect pathogenic KIT mutations in even of less than 1% in your peripheral blood leukocytes. Then, of course, myeloid NGS is also important. You should do this in all patients with advanced systemic mastocytosis, because up to 82% of patients with advanced systemic mastocytosis will have associated mutations in one of these, usually your epigenetic regulators or your spliceosome or transcription factors. And also up to 60% or more of patients with advanced systemic mastocytosis usually have an underlying hematological neoplasm. And these are also the molecular mutations most commonly seen in these myeloid neoplasms. Then, of course, it is important to screen for your PDGFR alpha and beta gene rearrangements, especially if there's eosinophilia, because, of course, this would then identify a different entity, a separate diagnosis that would be treated differently. And then lastly, I would just like to end off with this study that I thought was very interesting from Craig et al. What they did was they looked at 8 years of data of patients that were diagnosed with some kind of hematological malignancy, myeloid malignancy. And all of these patients, as part of their diagnostic workup, had NGS myeloid panels done. And they noted that 64 of the patients over the last 8 years, they picked up pathogenic KIT mutations, but didn't make much of it at the time. It was probably low frequency, or it was just in the background of lots of other mutations. But then of those 64, 40 patients actually had the specific KIT D816V mutation. And then with further sub-analysis, they noted that 22 of these patients had a diagnosis consistent with either a MPN, a MDS, or a MPN-MDS overlap. And then 20 of those 22 patients, so 91% of these patients, when they went back retrospectively and reviewed those patients' morphology and immunophenotyping, actually fulfilled the criteria for systemic mastocytosis. So they actually went as far as to say they proposed that when you identify a KIT D816V mutation in a patient that is diagnosed with either a MPN, a MDS, or a MPN-MDS overlap, or even an AML with a myelodysplasia-related changes, that it should trigger reflex testing for systemic mastocytosis. A similar study by Schwab et al. Found the same, but they even found the reverse, where they said that up to 16% of their patients that they initially diagnosed with indolent systemic mastocytosis, once they had started treating the mastocytosis and the mast cell burden decreased, they realized that this patient actually had an underlying hematological neoplasm, but it was just masked by the mast cells. And with that, I'm going to hand over to Jack again.
Thank you, Annika. That was brilliant. Let me just quickly share my screen. So everybody ready to answer the questions? I'm just gonna. All right. So I want to see. The question is what? Looking back at my case, what subtype of mastocytosis after Annika's brilliant presentation do you think my patient, Mrs. CJ, have? So I see there has been some answers. So I want to see if, let's give it a minute. Let me know if it's not working. As I said, this is the first time I use this, so we get a good cutaneous. I see there's only been 3 or 4 answers. There's quite a few people on the call. Let's see how many we have. So we should be getting more answers. Oh, sorry. Right. So I think that so I've just to note that I see there's the well-differentiated systemic mastocytosis, maybe with the absence of the KIT mutation, the prominent skin disease, I'm not sure. So I think smoldering, she didn't actually have any evidence of bulk. Bone marrow was only about 1% on the aspirate, and although there was an interstitial and focal mast cell infiltrate on the trephine, it was less than 30%, and there was no dysplasia. Cutaneous mastocytosis, I think, yes, she does have cutaneous involvement, but she clearly had, one could argue maybe a little bit about the major criterion, because it says multifocal areas, which wasn't, I mean, on the trephine of 2019, there was a single area of about 20 mast cells, but there was an interstitial presence. On a subsequent marrow, there was other, I didn't show that one, but there was again a focal dense cluster of mast cells present. She had persistently elevated serum tryptase. More than 25% of the mast cells were abnormal, and I didn't actually show that they expressed CD25. So I think Let's see if anybody said indolent. There's a smoldering. I say that would be that's not the case because there's not burden. Definitely not mast cell leukemia. It was less than 20% on the bone marrow. So I labeled her a indolent systemic mastocytosis. I'm quite welcome to take alternative views, but so I sort of made a diagnosis of indolent mastocytosis. All right, so let's move on to, there's going to be another question at the end of mine, at the end of my talk. So I'm going to talk about the management of systemic mastocytosis. And there's various categories of therapies that one can talk about. So the first is observation and with avoidance or trigger avoidance, then focusing on symptomatic treatment to reduce mast cell mediated release symptoms. My patient had very marked mediated release symptoms. Supportive measures to manage this osteoporosis, which they often have. In my patient, didn't have this or doesn't have this, and then transfusional support as needed, and then specific cytoreductive and targeted therapies. And then a question about, are there patients that will benefit from stem cell transplant? So it's important to talk to your patients about possible triggers, and this varies quite a bit from patient to patient. Some patients get triggered by heat, humidity, and cold. Emotional stress seems to be quite common. Exercise can trigger it, certain foods and alcohol. And then insect stings, especially Hymenoptera stings, can trigger anaphylaxis, but also release of mediators, infections and fever, and then various drugs. And important to note, NSAIDs, and then antibiotics, especially vancomycin. And then anesthesia is, I think the anesthetist should also know about this condition, as various anesthetic agents such as muscle relaxants and local anesthetics may trigger it, although the local and regional anesthesia is generally safer than general anesthesia. Surgery itself can also trigger mast cell release. So interestingly, and Annika did allude to this, is that anaphylaxis is actually the most more common in the indolent subtype of mastocytosis, and become much rarer as the disease progresses to more advanced phases. And it's very important to educate patients about this, and they should have a alert bracelet. There should be an anaphylaxis emergency plan, and they actually recommend that patients have a sort of an action plan, or a plan, sort of action plan wallet card that they carry with them. They should have EpiPen, a self-injectable epinephrine, that they carry with them in case they develop symptoms. And then another important aspect is to, if patients, to where possible, measure serum tryptase levels post episodes of symptoms, to confirm that that mediator release was actually the cause of the symptoms. Symptomatic treatment is focused on combating the various mediators that these mast cells release. And as can be seen, the mast cells themselves aren't very impressed with us. We're not doing very well, as my patient clearly shows. She's on antihistamines, so H1 antihistamines that prevents the pruritus and flushing and vascular sort of symptoms. The H2 antihistamines such as cimetidine and ranitidine control the abdominal pain, heartburn, cramping, and diarrhea. And then anti-leukotriene drugs such as montelukast and zafirlukast and others, they can be added to the antihistamines if there's still flushing and pruritus and abdominal cramps that are unresponsive. So you can combine the two. Some would use, if available, I don't think we have this available, for patients with a current anaphylaxis, you can consider anti-IgE antibody emolizumab, or others, or short courses of steroids or no-dose steroids, and this then prevent IgE binding the Fc epsilon receptor on mast cell and prevents degranulation. Other things that can be used for symptomatic management and mediator control, flushing responds quite well to aspirin, but very importantly, it's that aspirin can trigger, and NSAIDs, as noted in the previous slide, can trigger mediator release and even anaphylaxis. So it is recommended that the first doses are given in a setting where action can be taken if there's a significant release in mediators. And often very high doses of aspirin is required, up to 500 milligrams, and this could be problematic in patients with peptic ulcer disease. The gastrointestinal symptoms, if the H2 antihistamines are not effective, cromolyn sodium, which is can be used systemically, so oral cromolyn sodium, which is a mast cell stabilizer as well, and it inhibits mast cell degranulation, and it's given twice a day, 2 to 3, 4 times a day, with meals and at bedtime for those symptoms. And if patients have associated peptic ulcer disease, you can add PPIs, as my patient is. Cutaneous pruritus that is refractory to antihistamines, topical cromolyn ointment can be used. I'll mention something on that a bit later. You could even use topical corticosteroids or narrowband UVB phototherapy. Just maybe to note as well that the refractory intractable diarrhea can be treated with oral or topical, or actually with oral steroids, short course of oral steroids. Patients with mastocytosis, especially indolent or any systemic mastocytosis, should be screened periodically for development of osteoporosis, and this will then be treated as you would normally treat osteoporosis, with calcium and vitamin D supplementation, bisphosphonates if they have osteoporosis, denosumab in refractory cases, but additionally interferon alpha, which has a stabilizing or not really cytoreductive. They induce they're not cytolytic. They limit the proliferation of the mast cells. May also be used to treat osteoporosis in difficult cases. This table is also from that AJA 2023 review. I'm not going to go through it, but I think the message is that for the various mast cell symptoms, there's usually a stepwise approach. For instance, with the pruritus, your first line would be the H1 antihistamines, cetirizine and hydroxyzine and others. You can then add the leukotriene antagonists, NSAIDs, but remember to ensure that they don't have do that in a controlled environment the first time, so that just to know that they are not ones that are triggered by this. And then the phototherapy can also be used. And then similarly for the other symptoms, there's the stepwise approach. So this is quite a useful table to have a handy in managing your patients. Sorry, my screen is not advancing. Oh, there we go. So this is a nice summary from a review, a slightly older review from 2020 in BJ8 Reviews. So if you've got a diagnosis of indolent systemic mastocytosis or smoldering systemic mastocytosis, you focus on if they're symptomatic, you treat the mediator with symptomatic therapy to address the mediator release. And then for refractory cases, you can consider cytoreductive therapy and some of the newer agents, which I will talk on. if you have a diagnosis of advanced mastocytosis, you will still, if they have mediator symptoms, you will use those medications, and then generally you would require cytoreductive therapy. If there's an associated hematological neoplasm, you need to decide which does both require treatment? Are both contributing to symptoms, or is it just the associated hematological neoplasm, or is it primarily the mastocytosis? And this can be a very difficult decision. On a recent, there's a very good webinar from February this year, which we could maybe share the link if anybody's interested, where even the experts, the experts in mastocytosis say that this is sometimes a very difficult or very challenging decision to make, which is the most important component to treat. But if the associated hematological neoplasm is requiring treatment, you direct therapy to that, and then question about stem cell transplant. Mast cell leukemia needs a specific cytoreductive therapy, and may consider multi-agent chemotherapy and transplant. Okay, so looking at where we are standing with cytoreductive therapies currently in systemic mastocytosis, the avapritinib is now indicated for first-line treatment in adults with advanced systemic mastocytosis. And it's a small molecule multi-kinase inhibitor that selectively inhibits the activation loop of various mutant kits, and especially also the KIT D816V. It's got significant side effects. So edema, cytopenias is sometimes problematic, and special note should be taken of thrombocytopenia, and the label will say that this is contraindicated with a platelet count less than 50. As in the phase 1 trial, 13% of patients developed intracranial bleeds, and this is a major consideration. So be very careful and monitor these patients' platelet counts. And then significant diarrhea is also problematic and impaired cognition. Registration of this agent is based on these two trials, the phase 1 trial, which showed an 84 progression-free survival at 12 months and a 63 progression-free survival at 24 months, and a median overall survival not reached after 23 months, and this is in advanced systemic mastocytosis. In the phase 2 trial also showed very good progression-free and overall survival at 6 and 12 months. This is quite short follow-up, so I mean this will probably mature as time goes on. To note that it's now also registered for indolent systemic mastocytosis with a focus on symptom reduction. So can definitely be considered in these patients who do not respond to mediator-directed therapy. And this is also at a lower dose. So the dose in advanced systemic mastocytosis is 200 milligrams, and in indolent systemic mastocytosis it's 50 milligrams. Midostaurin is a multi-kinase inhibitor. I think most of us know about it. It's used in, or it has a label for AML with FLT3, ITD mutations, and it's also got activity against KIT kinase domain mutants, and its label is first-line treatment for adults with advanced systemic mastocytosis. It's also got side effects of cytopenias and gastrointestinal side effects can be very problematic and impair tolerability and ability of patients to actually stay on this drug. The registration trial showed that the progression-free survival for advanced systemic mastocytosis was 28 months, with an associated hematological malignancy that drops to 11 months, and then mast cell leukemia also around 11 months. So mast cell leukemia much worse than just advanced systemic mastocytosis. And then the median overall survival was not reached for advanced mastocytosis, and less with associated hematological neoplasm, and then much worse for mast cell leukemia. And then there was another French compassionate use study where the overall response rate was 71%. About, if I remember correctly, 30 to 35% complete responses, and then the median duration of response was 17 months. There's also a possible role for midostaurin as a maintenance therapy after stem cell transplant, or in patients with severe mast cell mediator symptoms in indolent and smoldering mastocytosis who fail other therapies. Now, these two, the agents, I decided to talk about what is specifically mentioned in the literature as frontline therapies, but we often we don't have access to this, or access will be very challenging. These agents are not registered in South Africa and are very expensive. So there are other options. Cladribine is a nucleoside analog, which most of us know, used specifically in hairy cell leukemia quite effectively. So most of us have some experience with it. It leads to quite rapid reduction in mast cell burden. So many of the authors suggest that this could be used when there's an urgent need for mast cell debulking. However, the responses are usually quite transient and then followed with relapse. And this is specifically more so in the advanced setting. The responses are more durable in indolent and smoldering mastocytosis, with responses going ranging from 2 to 8 years in various series. So this is an option, I think, in our setting where we, with our backs against the wall with an indolent that remains very symptomatic. So interferon alpha is not technically cytoreductive. It's less cytolytic than the other agents, but it does reduce proliferation of these abnormal mast cells, and it's usually the responses are quite slow. So it's usually in patients only with slowly progressive disease who are not candidates for other therapies, or where, if you read the literature now, they talk about this in resource limited settings. So it's starting to fall out of favor internationally for the treatment of mastocytosis because better therapies are available. Interferon can increase bone density, and that's why it's mentioned as an option for treating difficult to treat osteoporosis in this setting. And while 50 to maybe 50 to 60% of patients do respond to interferon, major responses is in a small number of patients, 20 to 30%, and there's significant relapse risk and often toxicity with interferon. Patients don't always tolerate interferon well, with flu-like symptoms, irritability. I remember one of my patients who not have mastocytosis, a different hematological malignancy on which I used interferon. His wife threatened to divorce him if I don't stop his interferon, and I did go. He didn't change his therapy, something else. So yeah, the symptoms can be the side effects can be quite significant with interferon. We obviously only these days use pegylated interferon, which is generally tolerated a bit better than the standard interferon, which is in any case not available. So imatinib does have a place in mastocytosis, but it's only for patients with unmutated KIT or KIT mutations outside of exon 12 that are known to be sensitive to imatinib, and in the well-differentiated systemic mastocytosis. Keeping in mind the very important slide that Annika showed about ensuring that your KIT testing is up to standard to avoid false negative testing. Hydroxyurea can be used if the associated immunological neoplasm needs a reduction in white cell count or splenomegaly. There's a few new things that's literally come onto the block this year or end of last year. The two agents, bezuclastinib and elenestinib. These are, again, potent and selective KIT inhibitors. And I think if I understand correctly, the main reason for the development of these is that they don't cross the blood-brain barrier, limiting the central nervous system toxicity and hopefully decreasing decreasing the risk of intracranial bleed, which is a problem with avapritinib. They both are effective, but they're still quite early phase, so they're not registered yet, but they may come in the future. And then lastly, the question about stem cell transplant. And it's the only treatment option that may cure advanced systemic mastocytosis, and it prolongs overall survival and progression-free survival in selected patients. The experience is skewed significantly towards mastocytosis with an associated hematological neoplasm. And especially now in the modern KIT inhibitor era, which is there, but we're not currently probably part of the modern KIT inhibitor era. It's thought that stem cell transplant has the main utility in addressing the associated hematological malignancy. If that malignancy requires transplant, the patient may benefit from transplant. So that's the current feeling of stem cell transplant. Overall survival at 3 years is around 57%, so reduced intensity conditioning and mast cell leukemia significantly predicts for much shorter a median overall survival. All right, so with that, the next question is coming up, hopefully. Why is it not coming up? There we go. So how would you, my patient, what would you recommend as a treatment for Mrs. CJ? She, just to reiterate, she's still got significant mast cell symptoms despite extensive use of anti-mediator therapy. She's got indolent mastocytosis with KIT negative. So what would you treat her with? Is it working? I don't see any responses coming through. Ah, there's one response. Let's see.
It
So
is working, Jacques. I don't know if our heads are working.
That could be. That could be.
You pose hard questions.
I see imatinib coming up. Is it showing on the? Yeah. See imatinib coming up. Any other suggestions?
Okay.
Omalizumab, interferon. Let's give it a few more seconds and see if there's any other ideas. In the interest of time, I'll leave it up there. So I think I did the same thing. I started on imatinib, and she's not really had a great response. And she does report some improvement in some of the symptoms, but I'm wondering if that's how she especially mentioned arthralgia as being better on imatinib, and I'm not sure if that's actually pleiotropic or off-target effect. I then after that she opted not to stop imatinib because she feels it does make a bit of a difference, but it's not been a dramatic response. Which brings us back to the point that Anneke made, that the correct testing should be done. So I suspect that this may be a false negative KIT case, because it wasn't done with a digital droplet PCR or the allele-specific oligonucleotide PCR. So I suspect this is a false negative one. Was considering interferon, which was unfortunately declined by her medical aid. Currently what she's on is, I wasn't aware of topical cromolyn chromoglycate. It's not actually available in South Africa, but there is a compounding pharmacy which can compound this. And she's been using topical cromolyn ointment for the past year, and with significant improvement in her skin symptoms. And a main burden was around the skin, the pruritus, and she's had a good response to that. And one could actually even consider giving her systemic oral cromolyn. Barring that, I do think maybe using, I have discussed cladribine with her. The responses seems good in indolent, and some series up to 90% good responses for the indolent subtypes. And then, if available, things like avapritinib may be considered in refractory cases. I don't think a stem cell transplant in this case would be indicated currently. Hydroxyurea, I doubt, will work. She doesn't have splenomegaly or high white cell count. So yeah, these are options. I think it's not always straightforward, but I think the ideal would be avapritinib, actually, if one could get hold of it. Now, my patient's main concern was actually, is this disease going to kill her? Like this elephant most likely would do if you don't get away from it. So we've not actually answered her main question, and that is, what is the I'm just going to get past this slide. So what is the risk of a disease? In the last few slides, I just want to touch on that. So the prognosis of mast cell leukemia, or of systemic mastocytosis, are quite varied. One of the main determinants is the subtype, the WHO subtype, with indolent mastocytosis. Actually, if you look at the population, expected population survival, indolent mastocytosis does not have a survival much different from the general population. But once you get to advanced mastocytosis or mastocytosis with an associated immunological neoplasm, that prognosis dramatically decreases, with a median overall survival in the range of probably 3 to 5 years, and then dismal prognosis. You actually miss this the mast cell leukemia curve there, but dismal prognosis in general for mast cell leukemia, with range from 2 months to 2 years, depending on the series that you're looking at. Her main concern was progression, and what is the risk of progression? And I could alleviate her fears a bit by stating that indolent systemic mastocytosis got a very low risk of progression or transformation, of about less than 1% risk of progression, and between 1 and 3% risk of progression. Just noting that smoldering mastocytosis has a significantly higher risk of progression of 18%. And there's some predictors such as serum beta-2 microglobulin and multi-lineage presence of KIT mutations, if it's present not only in the mast cells but in other progenitor cells, non-mast cell cell lineages, and older age and raised ALP. She doesn't have any of these present, although the KIT mutation is maybe not ruled out yet. There's various prognostic models. The Mayo Alliance prognostic system is a clinical and molecular risk model. So there's various clinical features looking at the WHO subtype, advanced versus indolent and smoldering, older age, cytopenias, and ALP, and then the mutations associated with poor risk, such as ASXL, RUNX1, and NRAS. And then one can see quite broad differences in survival depending on this risk model. The mutation adjusted risk score is another one. and this is specifically for advanced advanced systemic mastocytosis, and very similar, but just to note that the mutations in this series is a little bit different. SRSF2, ASXL1, and RUNX1, they talk about the SAR mutations. And then lastly, there's also two others, the global prognostics for mastocytosis. I'm not going to go into detail, I just want to show these scores. But maybe to note that the International Prognostic Scoring System for Mastocytosis, interesting that skin involvement is actually a favorable prognostic factor in advanced systemic mastocytosis. So just something to note, that the presence of skin involvement is good in terms of outcomes. Yeah, so I think in summary, my patient I assessed as having indolent systemic mastocytosis with troubling symptoms, looking towards possibly looking at cytoreductive therapy if she doesn't respond to the current, or progress or relapses or get worsening symptoms on the current therapy. I can tell her that hopefully her risk of progression is quite limited, and her expected survival matches the general population. Right. So with that, it's the end of our talk on anger management of mast cells. These cells can cause lots of trouble, but with sort of a good approach, one is able to maintain our patients' well-being and improve their survival. All right. I just want to check if there's any questions. Yeah, I think Garrick just noted there that the anaphylaxis and skin symptoms gets better with more aggressive disease, and I also wondered why, and I haven't seen a explanation for that. Annika, I'm not sure if you came across an explanation for that.
No, Jack, no, I didn't.
All right. So if there's no further, let's give a few more seconds and see if there's any questions.
I don't have a very clever remark, a very practical one. It was beautiful, really, Annika and Jacques, fantastic. So well
Thanks,
done.
Estelle.
And it will remain in our minds like the elephant that never forget, isn't it?
Yeah, that's another analogy.
Right. I know that Paul Ruff, when I met him, when I was a very young hematologist, he said this is his sort of disease that his sort of secret cherished disease. Now, all I can say is it's very secret. I also think it's amazing, but it's very secret where I practice. There is, I don't know if the dermatologists snatch them all away from us, the indolent ones, or the skin, but we don't see it. We don't see it. So I wonder if it's a regional thing, or if there's a genetic thing. Why do we see almost nothing in Cape Town? I don't know if, yeah.
Yeah, I think, I mean, in general, as mentioned, it is a rare malignancy. It may be, I think the dermatologists do see I mean, I've spoken to some of our local dermatologists about them. They see it from time to time. I must say the dermatologists locally tend to refer them to adults to us, as you should, if you have a patient with cutaneous mastocytosis, to refer them specifically for workup of it. So I'm not sure if it could be that patients are missed, but it is certainly a rare disease. I've personally been involved in, I must count this correctly, three patients with indolent mastocytosis, and years ago, when I was a fellow, there was a patient with advanced mastocytosis in our clinic. So it's certainly rare. So I'm not sure how often one sees. It's just, I think when you do get confronted with a consultation about this, it's always a bit of a panic-invoking consultation, because we don't see it every day. It's just nice to review it every now and then, just to that you're not completely caught off guard. And sort of, I think if you have the principles of how to diagnose it and the basic workup and then classifying the disease, you should be okay to start helping your patient. So that's why we thought to give this talk.
No,
It's
no,
interesting.
I didn't mean that it's not.
No, no, no.
I think it's a very important disease, and we treated quite a few in Europe. So I think it may be a genetic linkage because it was an important disease there. We saw many. So I think it's simply that it must be genetically confined or in regions. I'm sure you, and why would Paul Ruff have loved it as a very interesting disease? There must have been more in Gauteng. So anyway, it's just,
Yeah.
I miss seeing them. That's all I can say.
Yeah. It actually would be this maybe a nice side project for someone to see if one could get the data of
We'll have to speak to the lab people.
Well, yeah, from the dermatologist, how many
Well,
cutaneous ones they see, and if they do send them for systemic workup, it would be interesting.
yeah.
So
No, it's great and very updated. Lots of novel, drugs and ideas. Thanks.
Yeah.
I think everybody
unfortunately,
loved
novel
it.
drugs for us
I
is
just see excellent, very helpful, great. So
yeah, thanks, Estelle. Yeah, I mean, obviously the novel agents are not available to us, but we do have treatment options, I mean, available. But yeah, the new nice things, we're not quite there yet. All right, I think it's nearly past. So if there's no further questions or comments, we can end it there. Thanks everyone for attending. And as I said, next week there's no deep dive. Bridget and the team will let us know what the topic is for the week after that. And remember to fill in the survey. Bye-bye, everyone.
Thank you. Bye.